Dear colleagues, it's a great privilege and honor for me to welcome you all for the interesting meet that is Gastro GP Connect. We are a lot of people, no one in the medical fraternity without creating a gastroenterology case. I think I am correct. But we should know when to refer him or her to a gastroenterologist or when to not to touch the case. I have got a 40 years of experience and I definitely know which are all the cases should be touched, which are all the cases should not be touched. So likewise, all the young people, all the GPs should know what is their limit in the field of gastroenterology. That is the main aim. This is actually connecting the general practitioners to the gastroenterologist specialists. This is actually a bridge between the general practitioners and specialists. Very kind enough, our gastroenterologists from Salem, they have come over here to give us talk about different gastroenterology fields today. And I now request, this meeting is organized by the gastroenterologists of Salem and Indian Medical Association of Namakkal with the sponsorship of Torrent. Now I invite the President of Namakkal IMA, Dr. Satish Kumar, to come to the dais. Dr. Satish Kumar, currently working as a food safety officer, he got recently award from our Chief Minister of Tamil Nadu for the best performing district in the food safety. Congratulations, Dr. Satish Kumar. Next, I invite Dr. Palanisamy, none other than conferred Professor of Medicine of Namakkal District, Namakkal IMA. He is a man always with a book, medicine book always. He has a wide knowledge in the spectrum of medicine and I invite him for the dais. Third is the Dr. Shiva Shankar. He is the President of Gastroenterology Society of Salem. He is a very famous gastroenterologist at Salem. Now I request Dr. Rajesh, gastroenterologist of Gokulam Specialty Hospital, to come to the dais. The senior, I asked, who is the senior most gastroenterologist? Dr. Rajesh correctly told Siva Ganesan of Namakkal is the senior most gastroenterologist in our Namakkal, and I invite him for the dais. With this now, I invite the President of the Gastroenterology Society of Salem, Dr. Shiva Shankar, to just highlight about Gastro GP Connect.
We are going to have, this is a Gastro GP Connect actually. This is a program organized by TNISG. So Tamil Nadu ISG has welcomed all of our senior physicians, the senior general practitioners, senior surgeons from the Namakkal city for this wonderful meeting. Okay. I welcome you all.
Now let us go for the session. First session is GI and liver involvement in systemic diseases by Dr. Rajesh. I invite Dr. Palanisamy to chair the session. Rest of the people can come down, please.
Medical College, and he did his MD Pediatrics from Institute of Child Health, Chennai, Egmore. And after that he went to Stanley Medical College for MCH Surgical Medical Gastroenterology. He is now working at Gokulam Hospital 15 years. He is one of the leading interventional gastroenterologists doing special work on foreign body extraction, and the ERCP also he is well versed with all interventional procedures. He even also done bariatric balloon inside the stomach at Salem itself. He has done a very good job in gastrological field. I welcome you, sir.
Thank you, sir, for the kind introduction. So we'll move on to the topic straight away. So GI and liver involvement in systemic disease. So why I selected this topic is it's one of the common problems. So you say, anga adicha inge valikkum solvaanga illaya. So wherever you go, the patient comes to you with the GI symptoms, but the disease is not pertaining to the GI system. Maybe systemic diseases, they present with the GI manifestations. So I selected a few cases, I will not bore you. Various disorders, collagen vascular disorders, or oncological, hematological disorders, endocrine diseases, renal, neurological, cardiovascular diseases. For example, acute renal failure, they present with vomiting, and stroke patients, sometimes they may be a lower cranial palsy with the aspiration, dysphagia. You will be doing endoscopy will be normal. So patient with cardiac failure, patient with congestive hepatomegaly, congestive hepatopathy, like that. So critical illnesses, anything, any disorders, name it, anything can present with GI manifestations. And ranging from mild to severe critical illnesses with varied clinical presentation, they present with jaundice, abdominal pain, dyspepsia, vomiting, anorexia, dysphagia, diarrhea, GI bleed, organomegaly, anything. So we will just go one by one. It's jaundice in systemic diseases. You all know the bilirubin is formed from the senescent destruction of the senescent RBCs, the heme component converted into the bilirubin. So whenever there is more production of the bilirubin, there may be jaundice. So here are the two patients. This is the one patient, the young male. It's mild jaundice with anemia. It's another patient. It's a mild jaundice with anemia, paler. History is only fatigability, tiredness, suggestive of anemia. Pale is more than jaundice, no organomegaly. So diagnosis, the investigation showed total count is 3,800. So leukopenia, severe anemia with mild thrombocytopenia. So what is the diagnosis? Enzymes normal, bilirubin is indirect. Exactly, that's the diagnosis. So MCV is 110, similar to megaloblastic anemia, B12 is reduced. So no need for bone marrow here. So megaloblastic anemia, the jaundice is due to ineffective erythropoiesis. So this is after, most of the time it is all chronic, you need not do a transfusion. Even if it's a 5 or 6, just giving vitamin B, just vitamin B2 supplementation, they will improve. This is another patient. So we do 1,000 micron daily for 1 week, then once in a week for 4 weeks, IM. So this is another lady, young lady presented with anemia, again. Weakness, fever, jaundice, 1 week duration, short duration, drowsy, paler, more than the icterus, again, but organomegaly here. Sick patient, previous patient is a well patient, is a sick patient, more of anemia rather than jaundice. Here again severe anemia, but nucleated RBCs in the smear study. What does that mean? It is a hemolysis. Bilirubin is 4.3. Again, it's entire bilirubin, but enzymes are raised. That means the liver is involved here. Hence, the transaminase is there. But LDH is so high, retic count is high. It is a Coombs test is positive. That is a immune hemolytic anemia. So, what is the cause for immune hemolytic anemia? It's anti-double stranded DNA is positive. It is a SLE. It's a immune hemolytic anemia, SLE, can present with the liver involvement. Systemic disorders with the liver involvement, hepatitis can produce. This patient is sick patient, so treated by physician with steroids and immunomodulators, they improve. This is another case, 36-year-old lorry driver, alcoholic, presented with the fever, high-grade rigor, jaundice, loss of appetite, oliguria, deep icterus. So what is the diagnosis? Alcoholic is good, but fever, chills, rigor, splenomegaly, no, hepatomegaly, anemia. So this is a bilirubin is 42, creatinine is 7.6, enzyme raised, platelet, thrombocytopenia, ultrasound splenomegaly, viral markers dengue negative. So it is a malaria, falciparum malaria positive. The question again would be, this much of jaundice can they produce malaria produce jaundice? This much? We have seen, yes, severe malaria. We can see in patients. This is the patients treated with anti-malarial hemodialysis. See if it is an alcoholic, simple alcoholic hepatitis, they won't respond this much. Bilirubin 42 to 2.9 within a short span, within a month. So after anti-malarial, patients improved, the hemodialysis patient improved. So 5 days of short duration, only short duration, sir. his lorry driver goes to Andhra. So it is a smear study, smear positive, this patient is recovered.
What is the antibody that
That is artesunate IV is 2.4 milligram per kg of repeat after every 12 hours, then 3 days. Then along with we give the primaquine.
This case belongs to general medicine.
Yes, sir. That's why everything is all cases general medicine. So megaloblastic anemia is a general medicine case. So every case is only general medicine case. So I put. So what I have seen in the last 15 years, most of the cases, not always gastroenterology, general medicine also. That's why this is important. That's why I put the case. This is a 21-year-old male, jaundice, fever, 5 days, low backache, limb pain. Most of the cases I presented in AP also. And low backache, limb pain, abdominal pain, 7 days, recurrent jaundice since childhood. So patient is conscious, febrile, deep icterus, tachypnea. See, this is the patient. So patient complaining of severe back pain. If you see the patient has a tachypnea, deep icterus, patient is tachypnic, sick patient, deep icterus. Total count is 15,000, hemoglobin 5.5, platelet 3.3, MP negative. Any diagnosis? Bilirubin 25.2, protein SGOT, SGPT is borderline. Ultrasound abdomen, hepatomegaly, gallstone, non-visualized spleen. What is the diagnosis? Sickle cell. So whenever you see non-visualized spleen in ultrasound, that is not spleen, post-splenectomy, it is non-visualized echogenic spleen, shrunken spleen, it's autosplenectomy. So the only thing is, why this again is hemolytic jaundice, why put this much of hyperbilirubinemia, 15, and more of a direct, the liver in serology is negative, culture no growth, smear showing sickle cells. So treated with IV fluids, antibiotics, transfusion, paracetamol, severe pain, they make narcotic analgesics. So after 4 days, count has come down, coexisting sepsis, and bilirubin has come down. This is the patient at the time of discharge. So liver and sickle cell, it is an acute sickle cell hepatic crisis can occur, sickle cell intrahepatic cholestasis can occur, and again sickle cell produces a gallstone, this again producing a CBD stone. So prehepatic, hepatic, post-hepatic jaundice, all 3 types of jaundice can occur in sickle cell disease. Here, the non-obstructive cholangiopathy is due to the sickling in the end arteries of the biliary tree producing hypoxia and hepatitis. This is another interesting case. A young girl, around 14-year-old child, presented with cervical lymphadenopathy. FNAC was done outside and is non-contributory. They started on ATT, suspecting it is a tuberculosis. How many of you do ATT without tissue biopsy if FNAC is non-contributory? Cervical lymph nodes. No, that's one point I want to stress here. Yeah. So, okay, this is a patient, young girl, presented with cervical lymphadenopathy, FNAC done, non-contributory. They started as ATT, thinking it is a cervical lymphadenopathy. Patient is on ATT, after 3rd month, developed jaundice and referred to me as a drug-induced hepatitis. Okay, but the node is persistent. See, after 3 months, if it is tuberculosis, it would have vanished. It's a persistent. So we have done a cervical lymph node biopsy. So whenever the tissue diagnosis, whenever accessible part, you have to do tissue diagnosis. So ATT, so one thing, if it is drug-induced jaundice can occur, other things also possibility. Here, bilirubin is 13.1, SGOT, alkaline phosphatase is 568. So, but there is no obstructive joint, there is no CBD dilatation, intrahepatic biliary radical dilatation. So, cholestasis, intrahepatic cholestasis, there is a alkaline phosphatase definitely raised, bilirubin is raised. Biopsy is Hodgkin's lymphoma. So, this is jaundice is due to not due to drug-induced jaundice. It's a liver infiltration. This is stage 4. Patient is presented in early stage. We made it to stage 4. We referred for oncological center. This is long back, and we referred to a patient went to Chennai for Adyar, and the patient started on chemotherapy, and after 1 year expired. So this is an important point I want to stress. You always do a tissue diagnosis before starting ATT.
Sir, but this thing's okay. I had a patient with miliary, coronary miliary tuberculosis, radiologist impression on a chest CT. He has got progressive loss of weight, so many things. You want me to get a lung biopsy for
No. So that you have to do it. This is obvious.
accessible part?
Accessible, easily accessible part. That's the important thing.
It's also accessible nowadays.
So Sarvamani Rajamani is there, you can do that also. No problem. So sometimes patient present with an inflammatory bowel disease like thing. So 46-year-old male, acute abdominal pain, 1 week epigastric and hypogastric, more after food, loose stools. Patient is referred for endoscopy, but ultrasound showing ileitis, that is suggested ileal thickening. So anyhow, patient has all investigations are normal. I did an endoscopy. This is endoscopy. Sorry, it's all circumferential ulcers in the D2. Okay, so I said do a CT. Something is fishy here. It is not a simple ulcer. Okay, it's the second part ulcers, deep ulcers in the second part. And patient went back to the primary physician and not responding to a PPIs, prokinetics, persistent vomiting and pain. They did a CT. This is a CT. This is a bowel wall thickening here. So this is a bowel wall thickening. So this is again long segment of ileal thickening. Again, small bowel thickening. This is a trilaminar appearance. This is a comb sign. We see it's a Crohn's disease. We see comb sign. So naturally, they are given the diagnosis of CT imaging. Crohn's disease. So what is the Crohn's disease? It's an inflammatory bowel disease. The duration is long, prolonged period. What is the contradictory point here? It is a short duration symptom. Everything is short duration. So after seeing this report, the patient was referred to me for colonoscopy this time. So by the time they landed in my clinic, you see that this finding. What is the finding? It's a petechiae, diffuse petechiae, exactly. This is here thigh. It's a symmetrical palpable purpura, both sides. Diagnosis? Henna-Schwann purpura. So this is sometimes they present with pain. The other things, the arthritis, the renal involvement, maybe later. Not always, they all present with purpura first. So he had a joint pain, he had abdominal pain, skin rash. So here is the obvious diagnosis. No need for colonoscopy. Just because you have a colonoscopy, you can't do a colonoscopy here. This is a Henna-Schwann purpura, immune IgA vasculitis, treated with steroids, improved on tapering. Again, he developed a relapse. So because in Henna-Schwann purpura, biopsy is not an absolute requirement to diagnose. Because it's a clinical diagnosis. But if you have a doubt, this patient relapsed on tapering. So we did a biopsy. The biopsy came as IgA vasculitis. Actually, this patient, again, is one more patient, presented to me long back. I did a colonoscopy. Patient with blood and mucus diarrhea. For short duration, started with antibiotics. And metronidazole, and patient is not responded. So blood and mucus diarrhea, I did a colonoscopy. See, it's all ulcers in the ileum. It's all ileum, distal ileum. Other thing, cecum, colon, everything is normal. This is almost 30 centimeter, 35 centimeter. This is cecum, appendix. This is normal. So the ileal ulcers. This patient, after I did a colonoscopy, he developed a skin rash. So this is typical. You can see the symmetrical skin rash, both sides. It is a typical of Henna-Schwann purpura. So after starting steroids, patient responded. So another patient is 55-year-old female, presented a colicky, abdominal pain, 15 days, bilious vomiting, no GI bleed, no past surgery, abdomen is soft. In CBC, everything is normal. CT showed a long segment circumferential thickening in the middle third of the small bowel. But no obvious signs of obstruction, no proximal dilatation. So ESR is mildly raised. So clinical diagnosis is enteritis, whether it is infective or IBD. The CT they reported as is ischemic stricture, but that part going for ischemic stricture is less likely. and he started on IV antibiotics. Patient responded initially, again presented vomiting, subacute obstruction this time. So they did a laparotomy and resection of that segment, and anastomosis was done. Biopsy came as eosinophilic enteritis. So eosinophilia. This is eosinophils, more than 100 cells. So again we did it this time. Previously they had not done a smear study. He had done a eosinophilia. And so after recovering, he started on steroids and everything is improved. So you have to give elimination diet, 6-food diet, elimination diet, steroid short course. Actually this patient when taper, again is again developing eosinophilia. And I'm on budesonide now, it's doing well. Not always, not always. If the tissue diagnosis is there, it's okay. So this is another lady presented with the dysphagia. It's a 55-year-old female. Dysphagia, 2 to 3 years, both for solids and liquids, non-progressive, vomiting. She had 7 endoscopies with her. 7 endoscopies. Multiple places. Stricture, one place they reported was stricture lower esophagus, one the reflex esophagitis, the other endoscopy is normal. CT done, they showed thickening of the lower esophagus, very much normal. Investigation showed mild anemia. This is endoscopies pictures, multiple endoscopies done outside. So what is this? This is a barium study. Sorry, manometry. High resolution manometry. This is a normal manometry. You can see that this is a peristalsis. Here is a very weak hypotensive peristalsis, almost nil. But it's not achalasia. Here it is a peristalsis there, but it's totally weak, and LES is relaxed. So low LES pressure with hyperperistalsis. So this is a scleroderma. So why this is important is here, if it is a hiatus hernia, surgeons tend to take it for surgery for fundoplication. This is almost relative contraindication for fundoplications. So AN is strong positive, connective tissue disorder, scleroderma, esophageal hypomotility, hiatus hernia, grade C reflex esophagitis. Here the management is long-term PPA. The patient is on double dose PPA, is doing well. This is an interesting case. A 58-year gynecologist presented with the acute pancreatitis. First episode 2018. Amylase was elevated. Etiological evaluation at the time was negative. Done outside. Ultrasound is no gallstones. Serum calcium triglycerides done at the time was normal and improved. She presented 3 months later with again pancreatitis, second episode. This time I repeated the basic things and ultrasound showed acute pancreatitis, no gallstones. This is ultrasound finding. Any clue here? Able to see? What is the picture here on ultrasound? It's a kidney. What are you seeing? It's a calcification, nephrocalcinosis. It's a nephrocalcinosis. So this time we did a calcium is very high. It's a hypercalcemia that produces pancreatitis. PTH is high. So obviously it is a parathyroid adenoma. It is a Sestambi scan showing a high uptake in the left adenoma. She underwent parathyroid surgery. Yesterday she presented with again, not pain, this time with she's also hepatitis C positive. This time again hypercalcemia, again PTH, and ultrasound showing the other side, and waiting for the Sestambi scan.
Yeah, that time they didn't do 3/4
I think only one side they are done. Single audio, probably. Left side.
This is the initial scan, sir.
Yeah.
Grade 3
Right. So it done total,
you should do 3/4.
probably.
You should leave
It's small tissue parathyroid.
one parathyroid or should remove the 3 at least.
It's okay. Okay. Okay, the last case, I will not bore you. This is the last case. This is a patient, his child is presented to me Saturday evening at 8 o'clock. Acute abdominal pain. So, what are the diagnosis? Physicians, they will, with breathing difficulty one day. It's obvious. What are the diagnosis? This is a child presented with the acute abdominal pain with the breathing difficulty one day. Yes, it's a DK. Ultrasound abdomen is normal, chest X-ray normal. It's a chest X-ray normal. It is a this is a acidotic breathing. Sugar is very high. Patient is. So in conclusion, GI and liver is commonly involved in systemic disorders. Clinical examination is a very important thing. With the appropriate investigation, you can diagnose most of the time, most of the things, which leads to unwarranted investigation can be avoided. Sometimes doing colonoscopy in a national pulmonary is not good. And it leads to a good outcome also. Thank you. If you have any doubts, you can.
Any questions, sir? Any questions from the audience? Dr. Bhavish.
Just basically a basic question maybe in everybody's mind that LFTs derange or high bilirubin.
The question is whether bilirubin is raised, patient has fever, is it right to go with the paracetamol or not? Is still paracetamol is the best antipyretic if a patient has fever, even with the bilirubin is high. The thing is, if the prothrombin is normal, liver cell failure, you can still give. The only thing is patient is alcoholic hepatitis. Patients high bilirubin, because the metabolism is same, they tend to have a paracetamol toxicity very high. So the dose should be less. In a case, you can use you can use the low dose in a case of alcoholic hepatitis. All other things you can still use paracetamol. It's still safe compared to the other analgesics.
Thank you.
If there are no questions, shall I proceed? Now I request our IMA President Dr. Satish to give the shawl to Dr. Rajesh. Dr. Senthil Kumaran, physician, is presenting a book. Thank you, sirs. Next topic. He is the chairman of the Gastro Society, Dr. Shiva Shankar. Surgical management of GI malignancy. Chairpersons, Dr. Shiva Ganesan and Dr. K. Saravana Rajamanikam. Both of you, please come to the dais. Just. Shiva Ganesan.
First of all, I'd like to thank the Salem Gastro Society for coming all the way to Namakkal and enlightening us with the nice points of view from a specialist perspective. I'd like to introduce the professor and HOD of surgical gastroenterology from Salem Government Medical College, Mohan Kumaramanam Medical College, Dr. Shiva Shankar. He also, his hospital is also Nitish Gastroenterology Specialty Hospital in Salem. He's a very popular surgeon, very popular endoscopist also, and he is very passionate about malignancies. Welcome, sir. And he is going to talk today on surgery for GI malignancies.
Thanks, Dr. Rajamanikam, for the kind introduction. So this is going to be an interesting topic, actually, surgery for gastrointestinal malignancy, where we come across day-to-day clinical practice. And the previous era has gone. Big surgeon make big incisions. Nowadays, we prefer, because of the problem associated with the wound care, and patient developed endocotoneous fistulas and a lot of problems associated with the bigger wound. We prefer nowadays small incisions. So with the Yeah, Namakkal, I think is too far advanced with the having robotic with the is Dr. Rajamanikam, Saravana Rajamanikam is doing regularly. So this is all the things required for doing laparoscopic surgery and advanced surgery for GA malignancies. And with the use of a powered surgical staplers, we can achieve very good anastomosis, particularly the low rectal, colorectal anastomosis can be achieved. So where we come across very minimal leak from the anastomosis. So the principles same of laparoscopy for GI cancer is same as that of open. Achieving R0 resection, secure anastomosis, secure mode of retrieval of specimens, and similar or superior results of disease-free survival and overall survival regarding GI cancers. So I actually enlightened these with prototype cases. This is an interesting case of OG junction growth. Patient presented with the dysphagia actually. 1 second. The patient complained of dysphagia since 3 months, which was initially for liquids and then gradually progressed to solids. So this is the usual thing in GI malignancy, esophageal malignancy patients. Patient had associated vomiting immediately after taking food intake and associated with the loss of appetite also. So known case of hypothyroidism on tablet Eltraxin and stopped 10 years back. And the examination is everything okay. And CT abdomen, there is a circumferential wall thickening in the OG junction area. The patient was diagnosed as esophagogastric junction malignancy. 1 second. So this is laparoscopic. We are doing a diagnostic lab, and after ruling out the distant metastasis, we are mobilizing the OG junction area, and we start dissection along the lesser momentum and dissecting the OG junction, and we encircle the esophagus circumferentially, and we preserve the actually the dissection is around the lower third of esophagus in the laparoscopy. So all these things can be done in the laparoscopy, and we use harmonic scalpel for this bloodless dissection is achieved with the use of harmonic scalpel. And the OG junction fat pad is removed and dissection is done. And this is the thoracoscopic ports. So this is the usual thing with the Dr. Saravana Rajamanikam, I think. This is thing we are doing only concerned with the esophagus. So we dissect peri-esophageal dissection is done, and we dissect up to the ascygos arch level. Normally we remove we divide the ascygos arch, and this is the dissection, mediastinal dissection, and we take a special precaution when we going for dissection around the esophagus in the supracarinal area, because of the membranous trachea is very closer by. So we take a special precaution and we dissect the ascygos arch, both anterior and posteriorly, and we isolate the ascygos vein, where it enters into the superior vena cava, and we ligate the ascygos veins, And this is how we use clips also to better safeguard this azygos veins, because there will be a very torrential bleed if it is slipped off. And this is how we dissect the azygos, and after that we will divide the azygos, and then we proceed the dissection above. Actually, we include the lymph nodes also. The lymph nodes, particularly around the bronchial tree, there will be lymph nodes around the left bronchus and carinal lymph nodes, and everything will be removed when we go above. The dissection is up to the thoracic inlet. So this is the dissection, and the dissection should be very careful when we dissect around the left bronchus. Even the right bronchus, we have to be very careful, and the membranous trachea. So this is how we may likely to injure it. So at the same time, we have to remove the lymph nodes also. So the lymph nodes will be removed in toto along with the specimen. And the entire dissection, thoracic dissection, can be done to mobilize the esophagus. So the periesophageal mediastinal lymph nodes are resected en bloc, and the dissection is going towards the thoracic inlet above. So this is how the bloodless dissection can be very well achieved with the use of a harmonic scalpel. And sometimes we may have to use the ligashore also. And the thing is, there are very many vital structures surrounding, because the closer by there are bronchus, membranous trachea, and superior vena cava and pericardium. Everything will be there, so we have to be very careful while doing dissection. So we use the umbilical tape for retraction. So that we can the dissection can be done very easily. So the periesophageal area is avascular. We can easily achieve bloodless dissection. This is how we do the this intrathoracic dissection, and then followed by we close we let out the pneumomediastinum, and we will proceed with the creation of a gastric conduit, which will be done through laparoscopy, or probably we can make a small incision in the epigastrium. So this is the creation of the gastric conduit. The stomach can easily go into the neck area, so where we do the cervicoesophagostomy, and this is the final specimen after resection. So the postoperative course, patient had uneventful postoperative course, HPE, moderately differentiated adenocarcinoma invading the serosa, and 2 notes were positive, and patient subjected for June chemotherapy. This is another one case actually, a case of gastric malignancy. This is the very one of the most common malignancy where we come across in day-to-day practice, antropyloric growth. So we actually, in every patient, we will do the staging laparoscopy first, and we do, after ruling out the distant metastasis and assessing the resectability, we will proceed with the resection. This is the dissection in the gastrocolic momentum. So we always remove the momentum along with the specimen. So this is the dissection here. And the right gastroepiploic vein and the right gastroepiploic artery have to be ligated, and it has to be ligated and divided. And we use hemolock clips for ligating the right gastroepiploic vein. And this is, we use the vessel sealer. And because of the antropyloric growth, there may be some additions around the head of the pancreas, so we have to be very careful while dissecting. This is the right gastroepiploic artery. This is also to be divided, ligated and divided. So the nodal stations 6 also is dissected, and lesser sac is entered. And we do the lymph node dissections along D2 lymph node dissections. This is the duodenum first part where we actually divide the duodenum actually. This is the right gastric artery. Before dividing the duodenum, we are ligating the and the division of the feeding vessels have to be done. So this is the right gastric artery is divided with the use of vessel sealer. The nodal stations along the common hepatic artery, a node up to hepatodenal ligaments, and a node along the lesser momentum, and nodes along the main vessels like left gastric artery and proximal splenic artery. So I have to be resected en bloc. This is the stapler application. This is the powered stapler we use. Because of the use of stopless, we achieve very good anastomotic patency. There won't be any leak from the stapled area. Compared to the manual closure, the stapler closure is very good actually. So here we use the automatic powered stapler where we just press the trigger point. There won't be any need of maneuverability is not there with the powered stapler. So this is how the dissection. The left gastric vein is ligated very close to the insertion to the portal vein, and this is the left gastric artery is dissected and divided use of hemolock clips. So we can ligate also. We need not use the hemolock clips. We can spare the use of clips when we do ligation with the use of silk sutures. And this is how the dissection is done. And we use the staplers to divide the stomach. So it is adjusted so that we achieve at least 5 centimeter margin to be given proximal to the growth area. So at least 5 centimeter proximal clearance is to be achieved. And this is a case of antropyloric malignancy. So we are doing subtotal gastrectomy here. So this is how the stapler is firing, and we divide the stomach. So there will be some minimal bleeding may be there, but it will arrest on it spontaneously. So there won't be any need for any special suturing for arresting the vessel bleed. And we have to go to the lesser curvature region. So this is how we dissect and remove the specimen actually. So this is completion of the transaction. So this is the final one. So we may need to fire 3 to 4 also sometimes, because if the stomach is dilated very much, so in that situations we may use additional staplers also. So here approximately 3 staplers were fired, and here after the gastrojejunostomy has to be done to restore the GI continuity. So here we are using the stage stitches, and we again place staplers for anastomosing the stomach to the jejunum. So this is again same linear staplers can be used, and where we achieve good anastomosis. This is how the gastrojejunostomy is being done. This is actually, we make a rent in the stomach as well as in the jejunum side. So stomach side and jejunum side we have to make a rent to allow the stapler limbs to go through that. And this is all layers have to be open. And this is how the stapler is placed. So at the same time, we have to ensure that there is no mesentery cut in between. Any other structure should not be there. So that care you have to take care, and the stapler and bleed also have to be noted before going for the closure. So this is how the gastrojejunostomy has been done and complete the anastomosis. Okay, I will show another one video. Actually, this is laparoscopic left hemicolectomy. This is one lady presented with came with the complaints of abdominal pain since 1 month, insidious onset, present over the lower abdomen, mild to moderate intensity, colicky type, not radiation. So the examination, except mild tenderness over the left lumbar region, there is no anything remarkable. Findings: rectal examination normal, routine blood parameters normal. So serum CEA is 22 nanogram. So this is the one thing. And because of the lower abdominal pain, we did a CT. So CT showed a descending colon growth. So that is the importance of doing CT for unusual abdominal pain. So we have to, after that, a colonoscopy done, and we detected growth, and we took biopsy, and it was confirmed a descending colon growth. So this is how the where we have planned left hemicolectomy for this patient. So for a descending colon growth case, so where we identify the inferior mesenteric artery, so where we have to ligate it. So we use the hemolock clips, and this is how the hemolock clips is applied, and vessel sealer is a good instrument to seal the vessel, bigger vessels like this. So this is how you see the pulsation of the inferior mesenteric artery. So here we dissect along the mesocolon. So dissection is up to the inferior mesenteric vein above. So this is IME is identified, lateral to DJ flexure and dissected. This is how the dissection is. So it is secured with the vessel sealer, and we are dividing it inframesenteric vein. And then the dissection is above the towards the Tolles line, where we can identify the Tolles line laterally. So this is how the dissection is over the actually we have to preserve the perirectal fat, and if it is involved we can resect also. So the lateral dissection is done mobilizing the descending colon towards the splenic flexure. So this is how the dissection is being done, and the avascular plane. Actually, the medial to lateral dissection is the technique we did actually for this case. So we mobilize the splenic flexure, and we mobilize the distal transverse colon along the anti-mesenteric border. And the lesser sac is entered by dissecting the gastrocolic momentum. And we have to mobilize the splenic flexure, and by scoring the splenocolic ligament we are mobilizing it. All this can be achieved with the use of a harmonic scalpel. So this is how we separate it from the other structures. And proximal and distal transaction is done using a lap stapler, giving 10 centimeter margin on either side of the growth. So finally we can do the anastomosis. Colocolic anastomosis is the final one, approximating the transverse colon to the sigmoid colon area, because it is possible because we have mobilized to the colon, so that it will come off very easily towards each other. So after placing the stage stitch, we can similar to the kind of a gastrogenostomy, we can do the stapler application here. So the colocolic anastomosis can be achieved with the use of staplers here. So after application of stapler, we can close the rent with the use of 20 vicryl inner and 30 silk outer sutures. This is the specimen. And with the use of minimal incision, we can achieve all these things. This is how the port placement. So finally, I will show the last video. So this is a case of where we did left hepatectomy for this patient actually. So, this is a 60 years male presenting with the upper abdominal pain since 1 month associated with the mass abdomen. Abdomen showed a 7x5 centimeter mass in the epigastric region extending to the right hypochondria, moving with the respiration. Dullness note and continues with the liver dullness. Upper GI scopy normal and AIP is 40 nanogram. So triple phase CT showed a heterogeneously enhancing lesion noted in the left lobe of liver. This is how you can easily note that it is a left lobe liver mass. So this is how we do the left hepatectomy. It can be achieved by laparoscopic also. But here we did open hepatectomy. This is a parenchymal transection. After achieving the pedicle control, both inflow and outflow, we are making a parenchymal incision. After demarcation line is achieved, we made an incision over the demarcation line, and this is how the CUSA dissection is done, where we skeletonize the liver tissue and actually the vessels and bile ducts, biliary radicals, that alone can stand out while dissecting the liver parenchyma, so that can be ligated and divided. So this is the left hepatic vein where we achieve control by isolating it and secured by double ligation of left hepatic vein, intrahepatic. So after achieving, thereby we achieve the outflow control also can be achieved, and then we divide it finally. So the final part of dissection is being done, and this is the left hepatectomy specimen having growth. So it has achieved a R0 resection. So after we have to make sure that no bile leak should be there after achieving completion of a resection. So patient uneven full in the postoperative period and hepatocellular carcinoma. So it has been supported by the laparoscopic surgery, has been supported in the recent years by the so many studies we have for the support of laparoscopic surgery for colon cancer, colorectal cancers, as well as for gastric cancers also. There are long-term results we can achieve. So this is the oncological resection we have done in our department of GI oncology in Salem Medical College. So the upper GI malignancy we have been doing, and hepatobiliary malignancy and colorectal malignancy also. So even in COVID pandemic period also we have been doing routinely the GI oncology work. So in addition to the oncology work, the benign cases also we have been doing routine by laparoscopic method, and we do routine laparoscopic sleeve gastrectomy for bariatric patients also. So the conclusion, ladies and gentlemen, so the high-end laparoscopic surgeries and GI liver surgeries and GI oncology is possible with a good team, and it is safe, equivalent oncological results compared to open surgery, multiple post-op advantages. The future of surgery will move toward scarless and robotic again. Dr. Saravana Rajamanika may throw more light on this.
Thank you, Dr. Shivashankar. I invite Dr. Shivaganesan and Saravanan to give expert comments.
That's a fantastic work carried out in Salem Medical College Hospital. Hope a robot comes into the place. We'll have a Saravanan talk about it.
Sir, my only question is, sir, my father keeps on asking me, என்னடா நீ வந்ததுலேருந்து இத்தனை கேன்சர் வந்துருச்சு, so many cancers are there. What is your perspective, sir? Do you think there is a serial, you're in Salem, entire region's cases are coming to you. Are you seeing year by year number of cancer cases increasing coming to the OPD, or what is your perspective? Is it really a fact, or are we diagnosing more? Are we treating more? Are people are coming? Or
yeah, it is a combined factors. Again, people know that the cancers can be diagnosed early nowadays with the use of investigations. When we sit in OP clinic, they mostly whatever they have complaints, the first question is asking is there any cancer? I am having any cancer, so please rule out. So that is the one thing a patient actually asks. So in our routine OP clinic, so the actually patient are all willing to have a screening test. So probably we need to do more screening. So actually the incidence is high only. So we have been consistently seeing more type of these GI cancers, and we are operating. So we have our volume is not decreasing; it is in the increasing trend only.
PET CT is available. Do you have PET CT? Do you do?
PET CT, we are actually it has been planned actually already in GH.
Yeah, currently
We don't have.
they have planned, sir. Actually, both radiation mission and PET CT is coming in the near future.
Near future.
Thank you, sir, Dr. Shivashankar. We congratulate you for the excellent exhibition of cases. We are thrilled. Some of the cases are equivalent to Lokesh Karthik's Vikram. Thank you, sir. Oh, Prakash. I invite Prakash, the Namakal, son of Sahil. Gastroenterologist is coming to Namakal, sir. You also were invited. Dr. Satish, Idashal.
சார் சொன்ன மாதிரி நிறையா கேசஸ் வர்றது பார்த்தோன்னா நான் இன்னுமே சொல்லணும்னா இன்றைக்கி நான் எஃப்எஸ்எஸ்ஐயில் இருக்கிறப்போ நிறைய அந்த ஃபுட்ஸ் வந்து பார்த்தோம்னா கலரிங் ஏஜென்ட்ஸ் நிறைய இப்போ ஆட் பண்ணிகிட்ருக்காங்க. ஒன் ஆஃப் த ரீசன்ஸ் we are getting more and more of cases on gastroenterology is due to the food consumption of adulteration. நிறையா பார்க்குறோம், நிறையா பிடிக்கிறேன். கலரிங் அந்த மாதிரி கலரிங்லாம் இப்போ பார்க்கக்கூடாது. உங்கள் காலத்தில் நீங்கள் எல்லாம் பார்த்துருக்க மாட்டீங்க. நீங்கள் படிக்கிறச்ச ஸ்டான்லி எல்லாம் ரொம்ப நல்லா இருந்திருக்கும் ஃபுட்டு. இப்போல்லாம் அந்த பக்கம் நார்த் மெட்ராஸ்லாம் போகவே முடியல. வி ஹேட் கேசஸ், நிறைய கேசஸ் அந்த மாதிரி வராங்க. அண்ட் கேன்சருக்கு மேபி நிறைய வர்றதுக்கு காரணம் ஃபுட் அடல்ட்ரேஷன்ஸ். தேங்க்யூ.
Sir, he is against all 1 years. You know, I invite Dr. Shellokumar to present the book. Sir, go. Sir, thank you for the recipient and presenters. Next interesting session is a panel discussion. I invite Dr. Sendil Kumaran of Vellore, academic oriented physician. He is the next professor of medicine to the dais, please. I will invite Dr. Subasubramaniam. He is the son of the soil gastroenterologist. So, come on, Siva. He belongs to a small village, Vepanam, the 4-5 kilometers from Namakal. But he used to tell all Salem people that he is educated from Munford, but he is from government school of Namakal. I want to enlighten his past history, very bad past history. Now he is the best present history and future best history. Now I invite Dr. Rajesh of Gokulam Hospital to come to the dais. Dr. R. Karthikeyan. Dr. Karthikeyan, sir. Dr. Shivashankar again. Dr. J. Satish. These are the panelists going to discuss about acute pancreatitis. Actually, previously used to assure all the patients coming to me, don't worry, you'll become all right. We'll make you all right within 3-4 days. I stopped telling this after seeing a few cases of pancreatitis which I assured good recovery, but all the fellows died after 4 days, probably hemorrhagic pancreatitis. So that made me to think about the specialty. Now I invite Dr. Santosh Kumaran for his chairperson speech.
Respected sirs, thank you very much for giving the opportunity. My dear friends and senior friends, the incidence of acute pancreatitis varies in different countries and depends upon the cause, that is alcohol, gallstones, metabolic factors and drugs. Nearly acute pancreatitis 5 to 35 patients per 1 lakh per year worldwide, and the mortality will be more than 10%. It's a very devastating disease. It produces severe abdominal pain, epigastric pain, left hypochondriac pain radiating to the back, and produces hypotension, shock, and ARDS, and involving cardiovascular system and respiratory system, and kidney producing acute renal failure and ARDS, and complications like acute necrotizing pancreatitis and pancreatic pseudocyst and sealed off and other complications. So for this I invite Dr. Rajesh and Dr. Sivas and team from Salem to talk about, to discuss about the acute pancreatitis. Thank you very much, sir.
Thank you, sir. So next half an hour or so, we will discuss about, it is not only a panel sitting here, if anyone, if you have a doubt, we can interact. So, and as you are, and all the panelists here, they don't know the case. They are seeing it for the first time. So I have prepared this. So you all know the classification of pancreatitis. It is acute interstitial pancreatitis or acute necrotizing pancreatitis. Because why this is important is the mortality is high, 17% in necrotizing pancreatitis. The severity may be mild, moderate, or severe based on the local complications or organ dysfunction. The etiology varies. Commonly, it's the gallstone alcohol. In our populations, alcohol is more common than the gallstones. Diagnosis, you need 2 out of the 3 criteria. That is the pain, amylase or lipase elevation more than 3 times, and imaging. Any 2 is out of 3 is enough. And we will discuss about the severity assessment during the discussion. Coming to the management, is the pain management, the fluid therapy, and addressing the etiology. This is the important thing. These are 3 things you need to do. Coming to the case, he is a 41-year-old male, significant alcohol intake for the 5 years, acute abdominal pain for 1 day associated with back pain. There is no fever, breathlessness, no oliguria. Tachycardia was there with the mild hypoxia. Noctic, afebrile, abdominal distension was there, epigastric tenderness there, no guarding rigidity. Bowel was sluggish. Investigations revealed leukocytosis with amylase of 432. The ultrasound showing a pancreas obscured by bowel gas. Minimal ascites or left pleural effusion. So the question is, what is the diagnosis here? So whether the CT is needed or not. So I'll request Karthikeyan.
Thank you, Rajesh. I thank the forum for giving me an opportunity to discuss. Most common problem, as sir said, it has got a high mortality rate. So this is patient is presenting with acute epigastric pain with elevation lab values of more than 3 times of amylase elevation, and imaging ultrasound showed some pancreas is obscure. Actually, according strictly to speaking to the criteria, they are given out of the 3, 2 is enough to diagnose a case of acute pancreatitis. Since the patient is presenting with a case epigastric pain radiating to the back and the amylase lab value showing 3-time elevation from the baseline. So 2 out of the 3 criteria is enough. Ultrasound is the immediate imaging done nowadays. If the patient is having any serious symptoms or there is any doubt in the diagnosis of acute pancreatitis, you can proceed with the imaging, likely nextly to the CT abdomen.
Yes. So why this is important here is, CT is not required in all acute pancreatitis. If you have a doubt about the diagnosis, sometimes a surgical abdomen, peritonitis can present with acute abdomen perforation, duodenal perforation. Whether it is a peritonitis or it is a pancreatitis, then you have a doubt, you can do a pain CT to look for any pain CT, contrast CT, sometimes mesenteric ischemia, you can do that. If there is no obvious doubt about the diagnosis, no need for CT. When will you do a CT is in acute pancreatitis, if the patient is severe pancreatitis, if you suspecting necrotism pancreatitis, towards the end of the first week you do CT, because the time only you develop a clear delineation of necrosis you can identify. Otherwise, you have to repeat the CT also. So now routine CT in all patients. Coming to investigations for assessment of the severity and the etiology, these are the basic tests. So hemogram, LFT, RFT, and CRP 48 hours. And I have to look for a reduction in the hematocrit or renal function test over 48 hours if it is high at the baseline, and look for ascites and pleural effusion. So clinical examination is to assess for the early fluid losses, organ failure, whether respiratory with hypoxia, cardiovascular with hypotension, or renal with elevated renal function test. This is important. So it's done by modified Marshall score, and always look for the systemic inflammatory response syndrome. This is like a Marshall scoring for severity for organ dysfunction. This is a systemic inflammatory response syndrome, you all know. What are the risk factors for severe pancreatitis? If the patient has an age more than 55 years, or patient has obesity, altered mental status, a comorbid illness, patient has a systemic inflammatory response syndrome. These are the risk factors. By lab-wise, raised blood urea nitrogen, raised hematocrit is a very important point. Raised hematocrit at the patient presenting with the hematocrit of 55, maybe severe pancreatitis. So raising hematocrit, CRP more than 150 at 48 hours. Radiological wise, if it is a patient has a pleural effusions, pulmonary infiltrate, multiple or extensive extra pancreatic collection. These are the risk factors for severe pancreatitis. We have a lot of scoring systems. We commonly use Apache 2 or it's a BISAP, it's a uric clinical scoring. BISAP stands for blood urea nitrogen elevation. I stands for impaired mental status. S for systemic inflammatory response syndrome, age more than 60, and pleural effusion. So this gives a good score. So coming to the management, how do you manage this patient? This patient presenting with almost a moderate severe pancreatitis. First 48 hours, how do you manage in severe pancreatitis?
So regarding the management of pancreatitis, the three things are important: pain alleviation and IV fluids. And we have to address the other comorbid states in patient in hypotensive shock like that. So regarding the fluid management, that is very, very important to prevent pancreatic necrosis. So you have to give actually I used to give 250 to 300 ml of linear lactate solution and even the patient presents us initially to prevent circulation failure to the pancreas. That prevents further consequences and that prevents further necrosis. And we have to assess the patient subsequently, then we reduce the dose to 150 to 200 ml later on. At least even in cardiac patients, they develop pancreatitis, we have to give adequate fluids, at least 150 ml per hour should be transfused to prevent pancreatic necrosis. And then next, the pain management, we used plenty of analgesics. I prefer usually tramadol, which gives good pain relief, and it should be given 100 mg in normal NS over 1 hour. That is always safer. Direct injection of tramadol should be avoided. In certain individuals, I have seen patients developing seizures and patient developing acute shutdown, renal shutdown I have seen. So that should be taken care of, and preferably we give ondansetron also before giving tramadol. And other things we used fentanyl, all these things, pethidine, buprenorphine, we are not using those things, but bular patch now we can use in certain individuals, and it is very useful in chronic pancreatitis. Whenever they come with chronic pain, we can ask them to take a bular patch. And diclofenac, indomethacin and all we don't use nowadays, except we use them to prevent post-ERCP pancreatitis. So if we do ERCP, we inadvertently enter into the pancreatic duct, Then we want to prevent developing pancreatitis, we use rectal suppository of diclofenac or indomethacin. And we have to monitor the vitals. Very important is, as he said, hematocrit value should be monitored very stringently, and fluid management and pain, of course.
Actually, this is very important. Fluid is a very important thing. Even if you go by textbook, Western Standard 250 to 500 ml per hour can give. So in our population, we can't give 500 ml. As he said, you can give 250 to 300 ml, at least 3 ml per kg. And the goal-directed therapy. So what is the goal-directed therapy? So you have to keep the mean artery pressure 70, and you have to keep the hematocrit 40 to 42, and urine output 0.5 to 1 ml per hour. How to monitor? You can monitor these patients by invasive or non-invasive. The invasive thing is, we commonly do a CVP monitoring, but CVP monitoring is not always good in acute severe pancreatitis, especially patient is on ventilator. If the patient has a tense abdomen compartment syndrome, then CVP may not be useful. So you can monitor by stroke volume or arterial pressure waveform, and the best thing is non-invasive modality by looking at IVC diameter by ultrasound or ultrasound, lung ultrasound. See, this is a IVC. You can see the IVC diameter, whether it's collapsible or non-collapsible, and you can see the lung ultrasound. The pulmonary edema interstitial fluid collection, you can see the white lines. It's called the B lines you can see in the chest ultrasound. So fluid overload state you can monitor. These are the two things you can do non-invasively for monitoring acute pancreatitis. Coming to the myths in the management. So what are the myths? So people think that antibiotics improve the outcome in acute pancreatitis. No. The fact is, no routine antibiotics in pancreatitis. Systemic inflammatory response syndrome is inflammatory in pancreatitis in the first week. It is not an infective cause, it's inflammatory. And of course, you have to rule out extra pancreatic infections. Sometimes in acute pancreatitis, up to 20% they have extra pancreatic infections. The patient develops fever, do a urine culture, blood culture, other things, look for a chest. So other infection, yes, you have to give antibiotics and treat. Don't adamant that you should not give antibiotic in acute pancreatitis. So most of the time, in my patients, I never use antibiotics in acute pancreatitis. Prolonged antibiotic can go for complications and drug resistance. How about octreotide or somatostatin? So octreotide inhibits the pancreatic activity, it reduces the exocrine secretion, so hence it is useful. That is a myth. So what are the randomized controlled studies showed there is no beneficial role of octreotide or somatostatin in acute pancreatitis. So there is no role for octreotide. So what about the NG tube placement? So whenever a patient is referred to me, always come with a NG tube. So a routine NG tube is not required. NG tube aspiration, what is the myth is, it gives the rest to the pancreas and it reduces the abdominal distension. So no, again studies have showed not much of use. Unless otherwise patient has a tense abdomen with the ileus, vomiting, then it may be useful. Most of the time in our practice we don't give. In fact, we give a early enteral nutrition rather than the keeping the patient in oral. That is the concept in acute pancreatitis. So this patient treated with IV fluids and tramadol and oral liquids, just to see the patient improved. Coming to the second case, the 42-year-old female presented with acute abdominal pain, past history of biliary colic, jaundice 3 days, with no fever or chills, vital stable, epigastric tenderness. So imaging showed a biliary pancreatitis with a gallstone, the CBD stone, dilated CBD stone at the impacted the distal CBD impacted. So ERCP in acute pancreatitis. I request Sadish.
So this is obviously a case of mild pancreatitis, which we have to wait till it settles down and then do a, once the stone, usually it passes, then we have to do a lab chole. But the only indication, actual indication for ERCP in biliary pancreatitis, acceptable indication is the presence of cholangitis or sepsis, where you have to do a urgent ERCP. Urgent means within 24 hours. The other accepted is within 72 hours, which is called early. Other one, compared to one which is late, is around after 72 hours, which has, when you have just presence of stones in the CBD without the presence of cholangitis, then we can do a late TRCP. But only accepted indication is presence of sepsis or cholangitis. We have an impacted stone in the ampulla, then we have to go for ERCP.
Exactly. So whenever patient is severe biliary pancreatitis with the CBD stone, we do ERCP, or patient is cholangitis, we will do. But in our practice, if there is a persistent stone with the patient is a biliary pancreatitis, I do ERCP. But this is a patient, so where is the stone? It is impacted the ampulla. You can see the stone is impacted. So now good, nice black stone. So we did a pre-cut needle knife over the stone and pass the balloon over that and remove the stone. This is stone. So this is other indication. Patient presented with the biliary pancreatitis with the fever chills. So we did a ERCP. After sphincterotomy, you can see the pus, frank pus. This is stone removed. So this is two indications: ongoing obstruction and cholangitis. Rarely you can see sometimes these type of cases. Biliary pancreatitis, what I'm seeing here is a ascariasis. Almost 14 worms impacted from the ampulla. You can't wait here, no? You have to remove this. So we removed by using a side wing scopy. This is actually during my postgraduate period. This is from Stanley. This is a multiple worms, almost 14 worms we removed by passing 6 times, 7 times in side wing scopy. And next day we gave albendazole. The next day she passed almost another 20-30 worms in the stools. So this is all indication for ERCP in a biliary pancreatitis. When will you do a lab cholecystectomy, Satish, in a biliary pancreatitis?
Mild cases, index admission before discharge, we can do it. Suppose we have a severe pancreatitis, since the local complications will be there, we have to wait for at least 4 weeks before doing a cholecystectomy.
Yeah, exactly. This is the same protocol. So coming to the third case, it's a 31-year-old male, acute severe alcoholic pancreatitis, managed outside, presented with the pain, fever, breathing difficulty. The duration is 3 weeks. Now patient is systemic inflammatory response syndrome, fever, tachycardia, tachypnea, all inflammatory markers are raised. Imaging showing acute fluid collection. It's a necrotic collection with debris. I look at Shivashankar. So what is the plan of management here? The third week, infected necrosis.
Patient presenting with acute fluid collection and infected necrosis. In this scenario, we always go for a staged step-up approach. So what is step-up approach is we do drain the whatever collection. So by means of percutaneous catheter drainage, that is most easily available, and we can do the image guided, ultrasound guided percutaneous catheter drainage is very useful in this setting. And then after settling down the infections, sepsis, and the SIRS is settling down, and probably if patient is symptomatic, probably we can go ahead with the debridement or necrosectomy later.
Yes. Exactly, that's what we did. Actually, we given initially antibiotics, patient is not responding, and we did a percutaneous drainage. This is the amount of pus. And the patient improved. Again, the drain stopped and blocked and is removed, discharged with IV antibiotics, but readmitted with a fever. Again, same thing. But by the time it's a 5th week. So what I'm seeing here is a infected necrotic collection. So in single collections, posterior to the stomach with a fever, we did endoscopic procedure. This is a endoscopic view showing a bulge in the posterior wall. So I try to do a cystogastrostomy. This is a cystotome. I couldn't do a puncture with the cystotome because it is going tangentially. So then I used a needle knife. What we use it for ERCP. I punctured the cyst. Then see the pus. Pass the guide wire. Then dilated the track, the Suhendra dilator. You can see the nice coil. You have to make a coil inside the cavity. So then dilated with the Suhendra dilator. After dilatation, this is the second dilator. Up to 10 French we dilated. Then pass the stent. It is called Nagi stent. It is named after the Nageshwara Reddy from Asian Institute of Gastroenterology. It is a type of a lumen opposing metal stent. So this is a stent. Actually, it should be done under use guided. This is a better puncture. Only thing, but the studies have shown that it's a nice bulge. When a bulge is obvious, not much of difference. You can do without use also. That's what we did here. So this is a stent. It's a lumen opposing metal stent. So it's placed under fluoroscopic guidance and endoscopic guidance. It is a little bit gone inside. So I just pulled it a little bit so that it is open nicely. See, this is a necrotic debris. It's obstructing the lumen. By just pushing from the stomach from outside, it has come out. See, this is a nicely open stent. So no need to do dilate here. And some people, they put a stent, plastic stent inside.
Necrosectomy, some people do.
Yeah. So what we did is,
Wash.
no, this patient is improved. Actually, this is after CT. You can see this is a collapsed cavity. Stent is nicely open and collapsed cavity. Actually, we did the endoscopy after a week. I passed the scope inside. Actually, the want of time I didn't put here. I passed inside to see any necrosis, and there was no necrosis totally. I give a wash and come out. After 3 weeks, we removed the stent. The patient is doing fine. The fourth case, 34, same scenario, but the thing is, managed percutaneously 2 to 3 times outside. He presented in 6 to 8 weeks the duration. Fever, pain, breathing difficulty, everything, all set of complications. This is a CT. CT showing.
What was the total expenditure for that Nagi stent?
Nagi stent costs around 60,000. That's all. Total probably bill comes at 1 lakh something total. That's all. Actually, after putting a stent, the next, after 6 hours, he wants to take. So I'm passing his next day, we took food, and second day we discharged, third day. So, such is a relief after removing this.
There is one Boston Scientific tent which is 1.5 lakhs.
No, that is Axios, hot Axios stent. It is 1.2 lakhs, just 2 times. What is the difference between hot Axios here is, in endoscopic ultrasound, if you have endoscopic ultrasound, hot Axios is single, just like you're doing an endoscopy, just same sitting. You need not do a dilatation, no, same sitting, one single puncture, everything can come out. Cost again. So EUS cost, this cost, and stent cost. So this is again same scenario.
The advantage is patient going home 3 days.
Yeah.
Spending on ICU, antibiotics.
Yeah, antibiotics. Yeah, exactly. This is a patient presenting a necrotic collection again. You can see the multiple necrosis in the air pockets. And I request Shivashankar, what is the plan of management here? It's a necrotic walled-off necrosis, the infected walled-off necrosis, 6 weeks, fever with collections, left paracolic, pararenal.
This is quite obvious that the patient is having infected necrosis along with the infected fluid in the left paracolic gutter and retroperitoneal region. So this is actually ideal thing is in the 6 to 8 week setting, probably we can go for a video assisted retroperitoneal debridement. That is a very important procedure where we approach the collection through the retroperitoneal route along the left flank, and where we put the incision and deepen it, and we easily enter it without any difficulty. So, but the only thing is while doing dissection and where we retrieve the necrosis by blunt dissection, we should not injure the colon. So because it is very closer by, so one may tend to injure the colon and produce a colonic fistula. So that thing one have to be very take care. And we can do the laparoscopy, we can insert a nephroscope or any laparoscope inside, and we can debride the contents. Here I think the nephroscope.
Yeah, it's a nephroscope is used here. As you can see, a lot of pus and drainage is done. So removing the necrotic debris.
Classically spares the blood vessels.
Oh, they.
Very safe and should identify.
So this wash is given.
We can put a very large bore drains.
And it can go again and again also.
Yes. This is another bunch of necrotic tissues, debris removed. So these are the necrotic debris is removed. So this is a drain kept. This again is the one feeding tube is placed here. We keep on doing post-operatively wash, thorough wash. So this patient is improved. This is a CT after 4 to 6 weeks. Minimal air collection, minimal collections, only minimal here. So patient improved, is doing well. So in acute pancreatitis, the assessment of severity is very important. First 48 hours is very crucial in severe pancreatitis. The ringer lactate is the fluid of choice. We give 1.5 to 3 ml up to 250 to 300 ml per hour you can give. You can use the NSAID or narcotic analgesics. No routine antibiotics. ICU care with the monitoring for organ dysfunction and their management is very important. Acute pancreatic fluid collection. If it is infected, it needs intervention, whether go for a percutaneous or it is a surgical or endoscopic, depending upon the duration of the process. Whether it is less than 4 weeks, most of the time you go for percutaneous. If it is more than 4 weeks, the mature wall is formed. You can go for an endoscopic approach or a surgical approach, depending upon the anatomical feasibility. If it is only single collection, it's a posterior to stomach wall, nice bulge is seen, you can do endoscopically. If it is a paracolic gutter, you can go, or it's a long segment collection, go for a surgical laparoscopic approach or a ward approach. And if you want, you can continue or it can close. Enough? Okay, thank you, sir. We'll discuss the record.
One question.
Yes. So go open for questions, so we can discuss. The recurrent pancreatitis will postpone to some other day. This is Sarana.
Very nice presentation, sir. Sir, acute pancreatitis is one disease where even now, with all whatever options we are, it's very difficult to convince the patient whether he will live or die. It's one of the most severe things that can happen to anybody. Most of these patients will come invariably after alcohol binge, most of them. Forget the alcohol and gallstone. Most of them are after alcoholic binge, classically on Friday, Saturday, Sunday, Monday early morning. They will come and they will land up and abdomen so tense. And even with all of this, with good fluid management, mortality is still high. Has this changed, sir, in your perspective? Or
the two things. One is, yes, definitely with the ICU setup now, with the management.
I think early intubation, if required, early management of all that is very.
But whatever said and done, there is a certain group of population. Whatever you do, they will die.
They will die.
So sudden worsening.
What they are saying is the renal failure or the pulmonary failure or sepsis not improving even after aggressive therapy for more than 48 hours. Better refer the case to people who don't like, because he's definitely deemed to die. Moreover, another important factor is smoking. Most people aggravate the severity of pancreatitis when you smoke and drink.
Actually, when patient is relatively stable.
Another two things, Saranan, raising CRP. I've seen patient 700 CRP. Suddenly, within a day, it is.
CRP, according to, is a good predictor, sir, for.
And thrombocytopenia. The person with severe thrombocytopenia, prognosis will be very poor.
And another thing is, whenever a pancreatitis patient comes late, I consider myself lucky because now you can easily manage. You have many options of treating them, and if they are coming late, if they have done some 1 or 2 percutaneous drainage, the options are much better if we are able to tide over this initial 2 or 3 weeks. I think that is the biggest message that needs to be taken for acute pancreatitis. Very difficult not to do a CT scan in current era, sir. Vandu padutone, everybody will keep on asking, what is the problem? You tell him it is pancreatitis, sir, scan manunga. And it's very difficult not to do a scan. I think most of you invariably would have done a scan by at least 2 or 3 days. You don't do?
The problem with CT is, if you want to do it
has to be done
no, for establishing diagnosis, plain is enough.
Plain is.
But we don't advise contrast CT because already the renal function will be compromised, so it worsens the renal function. Suppose you want to see the degree of necrosis, day 3 to 5 is the ideal time for a contrast.
So day 3 to 5 is your suggestion?
For contrast CT.
For contrast.
How many of you strictly follow no antibiotics? I do give. I mean, they do have some one or other extra pancreatic.
Very septic and cholangitis
ARDS, organ dysfunction, yes, of course. But most of the time, there is 60-70% in mild pancreatitis.
In mild pancreatitis, we can differ. But
severe pancreatitis with organ dysfunction,
then definitely we should, because
tachycardia, fever, then
what they simply ask the patients, in the antibiotic, yes, sir, modale podla. Simply they will ask. So there is no answer for that question.
Sir, Dr. Satish, our IMA president, asked me a question before all of you came. He's telling 2 of his close relatives or known people had pancreatitis after cholecystectomy. Immediate, within 20 days of cholecystectomy. I could not answer him because I am not a specialist, but the panelists can.
Like even many of the patients we see passed out when we there is a clear-cut case of biliary pancreatitis, but patient all the time we see no stones in the biliary tree. So that is a scenario we come across actually.
probably
So
that
past-
is scenario, sir. Most 2/3 of the time when patient develop pancreatitis, stones are passed out. In this case, probably preoperatively, they would have missed a small stone, or during the surgery, there is small stone passed inside, it's only single stone, that stone also passed and produced pancreatitis. By the time we examine, no stones in the TPD, no stones in the gallbladder is knocked off. That is the only scenario, only explanation you can give. Yes, sir.
Mostly before lab coli, better to screen CVD.
So that is a,
People don't practice.
1 hour before doing a lab chole, the 10% of gallstones, they have a chance of CBD stones. So when you do a liver function test, don't expect bilirubin to be 3 or 4 to, if it is a rise in SGPT, SGOT, that is the most sensitive indicator of CBD stone. Whenever, for example, if you do a gallstone, do a ultrasound only cholelithiasis, CBD is normal, LFT doing LFT, all patients undergoing lab chole should have done a LFT. If the LFT is SGPT is 100, definitely you have to rule out CBD stone here. Because the sensitivity of ultrasound in picking up the CBD stone is less if it is a non-dilated duct. If it is a dilated duct, the chance is very high. It's a non-dilated duct, the chance of picking up the CBD stone by ultrasound is less, and is more, ultrasound is a subjective thing. So depending upon the person who is doing, that is a more important thing.
Cholelithiasis, we can have normal SGOTPT, the stone is above, not obstructing.
It's accepted, but the thing is, for example, if a patient has a cholelithiasis, you're doing ultrasound, only CBD is normal size, LFT is plumb normal. We cannot keep on doing MRCP for all patients undergoing lab chole. There should be something.
This is the reason why they do routine intraoperative cholangiogram in US. In all the centers they do
Routine, but it's not practically possible here, probably.
That is because, sir, the most litigated surgery in the United States is lab chole. More than even joint replacement. So everybody, when they are doing a lab chole, they don't want to get caught with any legal issue, so they do all possible things to document that everything was
This is the
normal.
thing, we can do health, but the thing is practical. What is practical? What should be done in, what is the guideline says? This is a, LFT is normal, ultrasound is, CBD is normal. If you are a very good sonologist, you can go ahead with the lab quality. That's what.
So one last thing, sir. Last question. We have treated pancreatitis, acute severe or non-severe pancreatitis. What are the long-term sequelae of a person who is undergoing pancreatitis? How to advise those people? They have survived pancreatitis, but definitely you would have seen people coming back with the recurrent pancreatitis. What is the advice? Do you see patients with the increasing diabetes, exocrine dysfunction post pancreatitis?
That's what. You could answer for this comes next to this one. Okay. If the patient has a recurrent pancreatitis, there is a chance of going for chronic pancreatitis. That's what recurrent acute pancreatitis. The one of the DD is early chronic pancreatitis. So always, if the patient has more than 2 episodes, all the etiological workup is negative. You have to closely follow these patients. They may go for a chronic pancreatitis. In that case, there is a chance of diabetes mellitus and exocrine insufficiency. Simple acute pancreatitis will not go for a calcification or chronic pancreatitis. Gallstone pancreatitis won't go for a calcific pancreatitis. Acute pancreatitis, alcoholic pancreatitis, recurrent, go for chronic calcific pancreatitis. Not acute pancreatitis, they don't go for.
Hereditary causes or autoimmune, they can progress to CC.
Later they may go for a, but I have not seen much of this severe necrosis, more than 50% necrosis.
You roll for open surgery in the olden days, no sir? In our college we used to open.
Open and close and open, close, laparostomy.
Alternate days open close.
Step up of course, now go for a bit drainage of the artery.
So now still
No, take the
open laparoscopy.
Yes, Deepti.
Sir, topic is very relevant even for us, although we are not from this thing. Because the thing is, here when we came, because of our general surgery background only, so until the person has seen the death of pancreatitis, they cannot realize the severity of, they take it, it's another infection. So for everybody's benefit, what is the cutoff? You want to give a single message. Some person is not doing well, when should you refer? 1 day tachycardia and all, 2 days, 3 days. How long the person should be managed in a normal setup without any intensive, very aggressive intensive care? First thing. CRP, do you start from the day one? Because a non-specific thing, any infection can give rise to, or how do you this thing? And third is, what is the early surgical intervention? Does it help or not? 3 things. One message, when should be referred, how long you should keep, 24 hours, 48 hours, 32 hours, like that.
Usually you can keep it first 48 hours. What is the whether it is a clinical, that is systemic inflammatory response in terms of decreasing, whether the hematocrit for example, you are doing today, the hematocrit is 48, 50, tomorrow you are doing 45, it is reducing, then you can keep the patient. There is no rise in tachycardia, there is not going for a tachypnea. So this type of patients and urine output started improving. Follow up with the IVC diameter, fluid, give hydration. Still patient is persistent elevation of hematocrit after 48 hours, 24 to 48 hours. Then, so you have to refer the patient. This is the patients. Then coming to the CRP. CRP at 48 hours is the guideline says, but if you do first day, CRP is again, it is 50, 60. Second day you are doing 150, 200. Then it may be a significant elevation. This one. Third thing,
Early surgery.
Early surgery. So no surgeon dare enough to take a pancreatitis, put a knife in first 4 weeks. I am sure.
No, sir. Necrosectomy and all.
That after 4 weeks. Yeah, we can do.
That only.
Duration is 4 weeks. Try to postpone the surgery as much possible. That is the dictum. Minimum 3 to 4 weeks.
No, sir. For the necrotizing pancreatitis, I am telling not that this segment.
So even necrotizing pancreatitis. Suppose, for example, the patient comes with 3rd week with the necrotizing. If you do a surgery, and you may develop further necrosis also. And another thing is, surgery is such a surgery. It increases the morbidity and mortality. So early surgery should be avoided. That is my.
Just for necrosis, only if it's an infected necrosis, you need to do surgery. If it's just necrosis, just wait and watch, see how it evolves over a period of time. When you have to intervene, you have to intervene. Be it months or year together, even it can present to 6 months, 10 months later also. So no surgery for non-infected necrosis.
And also, the patient is not symptomatic. So whenever the patient is no symptoms, no intervention.
The size doesn't matter. And also regarding that the transient, we come across more transient organ dysfunction. When there is persistent organ dysfunction, you should refer to the consultant.
I want to answer this question. When to refer, you asked. When you see a patient with pancreatitis with severe hypertension at your ER, with reducing saturation, and as Saravanan told, binge drinking, kindly refer.
Organ failure is not improving.
Sir, when does the mortality actually happen? Which period? Most of the mortality? In acute pancreatitis.
Early mortality is inflammatory response. Late mortality due to infections. Early mortality within 3 to 7 days due to hyperinflammation. The inflammatory response going for ARDS or hypotension, cardiac failure. So 2 phases. First phase is stiff inflammatory. Second phase is infection.
There are some cases we come across fulminant pancreatitis where we come across death within 48 hours, 72 hours. So, we can't make all right.
So the panel discussion end with the confusion.
No confusion.
Thanks for the wonderful interaction and wonderful discussion. Now I invite our IMA President, Dr. Satish, to shall Dr. Subramaniam. I invite Dr. Raja to give him a compliment. Come down. Sir, turn this side, sir. Okay. Photo. Thank you, sir. Now I invite Dr. Satish. I invite Dr. Aruna Prabhu, the peritoneal surface malignancy specialist from Namakkal, is giving a memento. IPAC. Sir, she is from Japan. Dr. Karthikeyan, sir. I invite Dr. Kumaraswamy, the senior physician from Namakkal. Because the memento may be the same book. So, Rajesh, I don't think Dr. Shankar needs again. Thank you, sir. Now it is a time for vote of thanks. Dr. Satish, President of IMA.
And thank you for all of the speakers to come to Namakkal, very small city. I am very happy to see all the doctors are youngsters. So I want to continue this section, second section also, on coming days. I thank you to all. Thank you, sir.
I thank Kuldev sir for arranging this wonderful meeting. So I request our President Dr. Shivashankar to give a memento to our Dr. Kuldev sir. Dr. Satish, next. Shivashankar. Sir, Pananiswamy sir. Vaanga sir. Sir, Senthil sir. Chuma amount va. Othar. Karthikeyan. Subramaniam. Vaanga sir.
Now we recognize the presence of former DMS, Dr. Influence Everin and his whole family. Dr. Influence, sir, you have come with whole family. சார் கார்த்திகேயன் டிஎம்எஸ் சார். வெரி பவர்ஃபுல் ஃபுல் நமக்கு சார். சிவகணேசன் வாங்க.
அதுக்குதான் இந்த ஒரு ஷாட்டுக்கு சார். நீங்க வாங்க சார். வாங்க சதீஷ்.
சதீஷ் வாங்க. நீங்கள் திருலிங்க இருந்தது. ஓகே. இப்படி விக்ரம் படம் பார்க்குற மாதிரி இருந்தது.
விக்ரம்ல ரொம்ப இம்ப்ரெஸ் ஆகிட்டு சார்.
ஒன்றும் பார்க்கல சார். பார்க்காம இம்ப்ரெஸ் ஆகிட்டு. தேங்க்யூ சார். எல்லாம் கொடுத்துச்சப்பா. யார் கொடுக்குறது?